when our basic needs don't seem so basic. When even business as usual feels like a world away. In these moments, we keep going. Because getting the right eye care is too important to stop, and receiving optimal treatment can save patients' sight. In these moments, we test, donate, research, produce, and do everything we can for those who need it the most. And even though we might feel alone, we join forces because we know we're stronger together. Because the visions that seem most distant are the ones worth reaching for. Health for all, hunger for none. From Bayer, we want to thank all healthcare professionals like you for their commitment, dedication, and support during these difficult, unprecedented times. Learn more about Bayer's response to COVID-19 at bayer.com/corona.
Okay, good evening, everyone. You know, it's another month, another episode. Welcome to the 17th episode of the VR channel, brought to you by the Vitreoretinal Society of the Philippines. Our night will be divided into three parts. The first part is the opening remarks by Bayer, our tonight's sponsor. The second, we have our main lecture, care of our guest speaker. And lastly, we have our open forum. But before anything else, I'd like to say happy birthday to Dr. Nico, who is our script writer. This is Dr. Cardo Nasol, your host, and I'm delighted to share this tonight's stage with my co-host, Dr. Kai Ariola. Hi, Kai.
Hi, Carlos. Thank you for welcoming me also to be hosting with you. And a good evening to everyone who is joining us on YouTube. Don't forget to like the video and click the subscribe button later to continue getting new updates. So for those joining us for the first time, the VR channel is a platform created by the Vitreoretinal Society of the Philippines to allow us to continue to share updates about various retinal conditions, even while we are in the middle of this pandemic. And we will continue to use this platform even beyond this timeline. But before all the excitement, Carlo, we would like to take this opportunity to thank our industry partner who made tonight's episode possible. Here is a short message from Dr. Odelia Lee, the medical advisor for ophthalmology and established products. Thank you again. And back to you. To Dr. Odelia Lee.
Hi, good evening, fellow doctors. So thank you. It is again an honor and pleasure to be here. And in behalf of Bayer, I would like to thank you for this opportunity to continue our collaboration. In the past year and months, we have learned a lot about healthcare, how to battle not just COVID, but many other diseases, and to adapt our practice to it. And I'm sure we will learn many, many more things. And life did not stop there. So we will continue to learn. And that is why we in Bayer fully support continuing like this, like the VR channel, which is also a fruit or result of innovation and your ingenuity. So again, thank you. I pray a fruitful evening for everyone and stay safe po.
All right. Thank you, Bayer, and thank you, Dr. Ali. At this point, so as with all previous episodes, we'd like everyone to kindly bring out their smartphones and scan the QR code flash on the screen on the right. Now, that will be flashed throughout the segment on the right hand side of the screen. Through this, we can make the session a bit more interactive as you can participate in the poll about the exciting topics. You can also post your questions and comments on the Slido app and alternatively on the YouTube chat box. We will try to address this in the open part of the session. And now, without further ado, let us all welcome our guest speaker tonight. Kai, would you do the honor of introducing our guest speaker?
Sure, Carla. Thank you again. So our speaker is one of the world's top experts in ophthalmology and in the treatment of retinal eye diseases. He completed his ophthalmology training at M&J Institute of Ophthalmology, Ahmedabad, in 1996. He furthered his training in the UK and completed his fellowship at the Royal College of Surgeons in 1997. Since returning to India in 1999, he has been practicing as a vitreoretina consultant at Retina Foundation and Eye Research Center, Ahmedabad. Our special guest has been awarded multiple awards in the span of his 20-year career, and this includes the following: the prestigious Distinguished Services Awards by the APAO in 2007, the Achievement Award of the AAO, or American Academy of Ophthalmology, in 2009, another award by AAO as International Ophthalmologist Educator in 2011, and the Achievement Award of APAO in 2012. In addition to all these international accomplishments and contributions, back home, he is one of the most recognized ophthalmologists and one of the most revered names in ophthalmic care in his city and country. He has combined the basic foundations of UK training with an extremely high volume clinical and surgical work in India. Being an early adapter of minimally invasive vitreoretinal surgery, he brought it back to his homeland and certainly helped his practice and patients. In his downtime, he relaxes by doing photography excursions with his wife and kids. This combines his love of family and nature. Ladies and gentlemen, please help me welcome Dr. Manish Nagpal.
Thank you so much for the very kind introduction, and it's been a pleasure participating in this wonderful event that you've been working on since the pandemic and trying to get connected amongst our colleagues so that we can share our knowledge and interact with each other. So thank you very much for this opportunity to be a part of the Philippines Vitreoretinal Society Forum. Thank you.
All right.
Would you like me to start the...
Sure, go ahead, Doc.
Yes, okay. Let me share the screen. Okay, is my screen visible?
Yes, doctor.
Yes,
Okay. So I'll be talking to you today on surgery for retinal detachment and PVR, and basically take you through all kinds of situations that one encounters when you see retinal detachment, and different ways of managing them and different techniques, technology, how the whole small gauge technology has facilitated the way that we repair these detachments in all sorts of modalities. So I'll be showing you some videos related to different situations, which could be a very starting from the basics of how retinal detachment is tackled in vitrectomy to some complex PVR based cases, and go on from there. In the meanwhile, you could put in your questions on the chat boxes as suggested, and at the end, we could discuss them eventually. Yeah. So when you see a detachment, a superior bullous detachment with a tear like this, you probably have three different options in mind in terms of a scleral buckling, a pneumoretinopexy, or a vitrectomy. Today, as we stand, primary vitrectomy is getting to be the most popular procedure in the way the things are taught in fellowship programs, to the decline of buckling surgery for various reasons. But then these are the procedures being offered, and pneumoretinopexy is also amongst one of the important procedures which can be used for these. Now, first let me take you through the vitrectomy part. Today, when we do a vitrectomy, the classic way is the small gauge. I personally like 25 gauge. It's a good balance between a 20 and a 27. 27 is a little fragile. 25 is sturdy and gives you the feel of a 20 and gives you access like a very small gauge surgery. So while tackling a typical case of retinal detachment by vitrectomy, your first step is vitreous removal. I typically use a wide field contact lens viewing so that I can see the fundus as a whole, and would start my procedure after putting the cannulas by doing a vitrectomy in terms of doing the core first and then trying to explore the peripheral areas as we progress and clean up as much vitreous as possible from all the sides before moving ahead with the next steps. So vitreous removal is the most important part. Now, when we say vitreous removal, you could get a case of a detachment when you go in with no previously existing PVD. This is a very important aspect, that you achieve a good posterior hyaloid detachment in every case, because otherwise that leads to a lot of post-operative problems. There could be contractions, PVRs will come in. And for that, you need a good technique, because in mobile retina, to use your cutter is very difficult at times because you don't have a hold of the retina, just like you might have it for a macular hole surgery where the retina is attached. So here we stain it with triamcinolone. And in this video, I've kind of done it in a slow motion to show you the exact steps of using very high suction after staining and then trying to get the vitreous out. So triamcinolone is a great tool to identify this kind of vitreous, especially when you have a mobile retina. So I'm going to show you a couple of examples so that the technique is something similar in terms of triamcinolone injection. You've done a core vitrectomy, then you inject triamcinolone, it will take up the stain if the hyaloid is still attached in this manner. And then using suction, you you try to find a right plane. As soon as you have a plane, you can start applying a kind of a tangential pull from there. Till that time, you have to sometimes struggle and try to find a plane amongst it and then clear up the vitreous. These are again some similar. This is a myopic case in which again we see that the hyaloid is attached, and you can see that I found a plane and then trying to pull it with high suction so that the sheet separates from the underlying retina. And as soon as it separates, then you can get the whole vitreous is available for you to just eat it up. Before that, it's dangerous to eat it up because it's got so much attachment to the retina that you could easily form an iatrogenic break in these situations. Now, if it's a phakic clear lens eye, again, there is a complex situation because you can't take the cutter to the periphery. So in these cases, what I do is I use a chandelier light so that I have bimanuality and I use my one hand to indent the periphery. I prefer the independence of using my own hand. You could also have an assistant do that. But here, the chandelier illumination is on and I'm using one hand to indent so that and reduce the IOP infusion pressure to about 15 or 20 so that I can indent easily. And then bring it towards the center so that my cutter doesn't have to touch the shaft of the lens in a patient who has a clear lens, and the lens is in a position where you can touch or create a opacity there. So this is a typical way that I would indent and do in phakic clear lens eyes, the vitreous removal in the periphery. Now, once you've done the vitreous removal, the next step is to do an air fluid exchange. Now, this step is done once you are totally sure that the vitreous is out, your hyaloid is out, and you're also checking for the mobility of the retina. I'll show you once again. So we've switched on to air, and you see these bullas coming up very nicely over the disc, and this is a good sign that the retina is freely mobile. And as soon as the air comes in, it pushes the fluid, creates the bullas, and you go into the disc to aspirate it. And once you've done that, you go to the break or take a retinotomy based on your plan to do an endo drainage. In this case, I'm draining from the break using a soft tip cannula. And you can see gradually how the reflex of the retina comes back as the fluid is drained, and it flattens up. So this is the sequence of steps which is followed. Now, there are some variables. At times, what happens that I've cleared the vitreous, I've removed it, and then I switch to air, and the bulla becomes posterior, and I find it difficult to aspirate from the break in the periphery. In that case, I put perfluorocarbon to push it, the fluid to the periphery so that I can go and drain from the existing break. Otherwise, the fluid gets trapped posteriorly, and sometimes you have to make a separate retinotomy to drain that. Now, a macula on RD, if it's there, I make sure that as soon as I've done the vitreous removal, I put perfluorocarbon so that this ensures that the macula is always flat, because you don't want the fluid to trickle down to the macula. Here, you see a detachment, inferior detachment with breaks, but the macula was on. So as soon as I finish vitrectomy, I put in perfluorocarbon. The fluid has kept the retina in context. And then the next step is that after having removed the vitreous, I go and drain from those breaks. Now, at all this point, the perfluorocarbon has made sure that all that retina in the posterior pole as well as up to the equator remains flat, irrespective of whether there's air inside or fluid. Because a macula on RD, you don't want the macula to get off at any point during the surgery. And then, of course, at the end, you always have to do a retinopexy in the form of an endo laser in most situations, which is carried out. So you would finish the procedure with that and then decide on a tamponade of your choice based on individual cases. Now, at times, I also use a cryo, like I showed you here. Sometimes the break is extremely peripheral and is difficult to laser because of the ergonomics. And at times, in very high myopic eyes, the break is not seen. So you may have done the surgery using a retinotomy to drain, but then you need to find the primary break. Here you see a slit-like tear in the periphery, which is showing up very well with the cryo. So I always keep a cryo on hand for such kind of cases. We use it regularly for buckling surgery anyways. So some of these cases also I would switch on to the cryo. Now, another situation yet you have a retinal detachment with a macular hole and a posterior break that you see. So there's a break posteriorly, there's a macular hole. So after doing the vitrectomy, we stain with brilliant blue. You can see that I'm peeling off the ILM. At times with mobile retina, the peeling can be difficult, and sometimes I use perfluorocarbon, but I always first give it a try without perfluorocarbon, because very often you can peel it off easily. The main thing is that you have to peel it away from the disc so that there is a hole on the retina from the disc. And after I've peeled, I've put perfluorocarbon up to the edge of the break, of the posterior break, which is there. And then I'm doing the endo drainage from there to flatten that particular retina, doing a laser to seal that. And so you've taken care of the macular hole with the ILM peeling, and then, of course, drained and done the retinopexy. These are multiple large tears, as you can see, with some early PVR changes, wrinkled edges of the wrinkled margins of the retina, as well as bridging vessels going over these large tears. So the first step is to go in and clean up the whole vitreous, everything in the interface, which is there, so that the retina is freely mobile. Now there's a bridging vessel, and I would like to diathermize it because these inadvertently get cut and start bleeding and create problems. So I prefer doing that. And once I know that retina, the vitreous is removed, I put perfluorocarbon so that I start getting a good flattening over the retina. With these large tears, you want the retina to be well flattened. The edges which are overturned, I would try to get them back. We use this instrument called the massager. I typically use it for macular hole surgeries to approximate the edges at times, but I also use it. It's an atraumatic instrument, just got a bullous tip, a smooth bullous tip, which is useful to carry out this maneuver. It doesn't kind of hurt the retina. It's very smooth, and gently you can move it and move the edges, iron it out gradually. So this is what we do under perfluorocarbon, and then of course do a good laser. I've zoomed in to show you this particular area with the same wide field contact lens that I use. Again, a case came with multiple retinal tears. Vitreous is being removed at this stage. You see the turbulence of the mobile retina all around, and once the vitreous is getting cleaned up, you can see all the breaks. Some are inferior as well, some are superior, and there's this whole concentric line near the equator of the vitreous attachment, which must have ripped off and during a PVD creation, natural PVD occurrence, which causes these kind of multiple tears. So once again, I show you the same strategy that I always do: a good vitreous removal and then put in perfluorocarbon. It always helps you keep the posterior pole at bay while allowing you to work on the periphery better, and it keeps the fluid out of the central area. And so I love to use perfluorocarbon for most of my cases in these situations. So here you can see that I've done a retinopexy. Sometimes I get carried away with the shape and I try to make a full heart out of it if it's a good horseshoe tear. But essentially, you just need to do your retinopexy. And in this case, it's a 360 laser because there are multiple breaks and I put oil in this particular situation. An example of a giant retinal tear, which we often encounter with patients having detachment. This is totally overturned, as you can see. And again, you need to first remove the vitreous. In these cases, do a good cleanup. Also remove the peripheral edge of the tear, as you could see here. And as soon as you feel that the basic vitreous is removed, then you can start injecting the perfluorocarbon to open up that whole, unfold the flap of the giant tear gradually. And in this case, we fill it up right up to the brim, going beyond the edges of the tear, so that that way you can reattach it totally, do a good laser 360 and finish it. After that, there are two ways to do it. I like to switch to air. I do a very gradual patient air PFCL exchange wherein I will keep the edges of these tears dry while the air comes in so that there is no slippage. So I will move around all 360 degrees, keeping the edges dry. And after that, I will go to the disc and remove the last bit of PFCL. While some people like to do a direct exchange from oil, which is also fair enough. And these are the two techniques that can be done at this particular stage. Now, let me shift the gear a bit to show you a buckling surgery. Now, the classic buckling surgery, which we do using indirect ophthalmoscopy, is what we've always been doing. About 5 or 6 years back, I switched to a chandelier-based buckling surgery after an idea I got while talking to a colleague. And what we do is that we use the same viewing system that I showed you. I use a contact-based wide field system and then put a chandelier illumination. And then along with that, use the classic buckling technique under a microscope. So we combine the good viewing of a buckling, of a vitrectomy procedure, and do the benefit of a classic buckling for certain type of cases which do well with buckling. Single breaks, fresh detachments, inferior RDs, young patients with clear lenses. Those are our indications. So here you can see that I put a chandelier light, and this is the lower bottom two windows show you the view that you can get. The view is the same as that of a vitrectomy, whether you use a contact lens or a non-contact, it's the same. All you do is you have to, after taking the muscles, the same way as for a buckling surgery, you put in a chandelier inside, and the light allows you to see inside. So a video to show you the procedure. This is how you see inside. It's a myopic eye with the infranasal area detached that you can see. I'm indenting the periphery. All this is being seen through with the chandelier-based viewing, and you see the break here, a small operculum. So now a cryo is being done. After doing the cryo, I localize the break first and pass a stitch posterior to the marked area and pass a sponge. And once I've done that, I do a drainage the, in the area inferiorly, just below the muscle. You can see the fluid coming out. And after that, we check inside. The retina has flattened after the fluid has come out. We confirm that, and now you can see the buckle effect quite well. So everything is like a classic buckling surgery, except that you've not used the indirect to see it. You do a vitrectomy-based viewing, which I feel is far superior of viewing than indirect ophthalmoscopy. It's better for teaching also. We have fellowship programs, and wherever you have to teach, you need to show what you're doing, where you're taking a suture, why you are deciding to take a suture here, how much cryo you are doing, how are you managing a drainage, how are you managing a bleed during drainage. All those things can be seen very well by these viewing systems, which are very difficult to show with the indirect ophthalmoscopy. So the steps are similar. You do a cryo, a localization, you drain, and then see the buckle effect inside at this particular point. And at the end, remove the chandelier. Another example of a young patient with inferior breaks, you can also see how well you can zoom in. I mean, all I do is with my contact wide field, I go and zoom into the area. You can see things much clearer. You can see every single detail of cells, pigments, everything that comes up, a cryo reaction, which is coming up and thawing. So it's a great tool to teach more than anything else. If you shift to a contact-based viewing system, chandelier-based system for doing a buckling surgery. And once again, I take a stitch after localizing. I do a diathermy, do a drainage to the area that I've decided to drain from, and press and indent and remove all the fluid which is there. And once all the fluid is gone, we would check inside to look at make sure there is no bleed, and also look at the indentation. And you can see the retina as well flattened. The breaks are over the buckle, well over the buckle, and it's a classic buckling surgery. I mean, this is exactly what you're used to seeing with inside the eye at the end of a buckling surgery. So we introduced this concept way back in 2013 and published it and in various peer-reviewed and other forums. And now a lot of teaching institutes, including the Duke at in the US, apart from many others, are also using the same technique now because they feel it's a great tool to impart the teaching which is there. So visualization is the key. I think it's how you view inside is very important. I mean, your view has to be good, whether you choose to do buckling, whether you choose to do vitrectomy. And it would be very easy for a surgeon who's comfortable with vitrectomy-based visualization to adapt to such a modality in case there's an indication for a buckle. Better visualization with zooming capabilities allow you to transmit, record surgery, and make it a great teaching tool. So these are advantages of this sort of buckling. So buckling still has a good role. It's just that it's a dying art. We are not teaching it as much as it used to be. The volumes have gone down, and naturally the new set of fellows are not getting enough volumes to work on. But I think if one could still keep doing it, keep showing it, there would be certain indications where I think more people can still manage to get away with a buckle in some situation. But of course, vitrectomy is gaining popularity. The instrumentation technology has been improving every year, and I think it's become a lot more safer than what it used to be many years back. Once again, shifting gear to more complex aspects. So from the regular basic management of detachment to going into management of PVR, which is PVR is basically nature's way of trying to get a detached retina back, but it fails and it proliferates and creates membranes, either epiretinal, intraretinal, or subretinal, and creates all kinds of havoc. We've published papers in the PVR, including a book chapter in the Ryan's Retina in the 5th edition and the 6th edition, and the 7th edition is right now ongoing, and we've contributed to the article as well as a lot of video clips which are associated with this article to teach various steps of PVR. So let me show you examples of PVR. The PVR can be as simple as a pucker with wrinkling, which comes up in a retinal detachment case if as time passes. And this is a classic example of a very nicely formed pucker, well formed, good margins, easy to see and remove. But of course, because there is the pucker, it's a good idea to also do an ILM peeling, because these eyes are prone to recurrent PVR changes, reproliferations, and so if you stain and remove the ILM, you have a better chance that it may remain stable at the end of it. So here you can see that we've stained with brilliant blue and then removing it. And once again, it's a detached retina, but the ILM peels fairly well without having to use a perfluorocarbon in this situation. So gradually remove it 360 degree around it. And then, of course, do your regular steps of air fluid exchange and then draining and settling the retina back. This is a case again of folds going from the macular area, ill-formed pucker. This is not as well formed as what you saw in the first case. So here you are left with the plan of staining and removing the ILM. So any ill-formed membrane also comes out with it. That's the best way to deal with it, because ill-formed membranes, you may not get a good edge on it. So these membranes, that's how we deal with. And in case it's difficult to peel on the mobile retina, we put PFCL. So here, in this case, as you see that I was finding it difficult, so I put perfluorocarbon and I'm trying to peel under the perfluorocarbon. So I keep the perfluorocarbon as a second step. In case required, I put it to help me peel. But in many cases, you can peel it without it, as long as you peel away from the disc, because the disc gives a good hold to the mobile retina. If you do it the other way around, the retina may start getting pulled with every step that you take to pull the ILM. This is a thick pucker with inferior kind of radiating thick fold which is going. So once again here, you can see that I'm removing that pucker. It's a very thick pucker which is totally constricted the macular area, and I'm removing that. And after that, after having removed it, we are testing, doing an air fluid exchange, and you can see that the retina tends to form the folds. But after I do the endo drainage, I can still see that there is a stress on the line coming from the lower break to that stria. So I make a retinectomy because this otherwise is, in the future post-operative period, will start to redetach and recontract. So one has to align a retinectomy to relax the concerned area during surgery instead of leaving it like that, because inferior area does not get tamponaded very well, and this is a classic area from where reproliferations are known to start. Staining is very useful for ill-formed membranes, just like I showed you in the previous case. Now, this is a case of detachment with no classic pucker anywhere. So in this case, we use the dual dye, which is made up of both brilliant blue and trypan blue. And this stains the surface very well. So you put in this dye and then put in perfluorocarbon over it. I learned this technique from Stano. He had showed at a few cases, and then you use a finesse loop to kind of define the ILM and the ill-formed membranes. The edges are well defined by this technique, and it also helps you iron out these wrinkled folds. Sometimes the membrane edges will come off with the ILM, and sometimes it just helps you iron out the folds which do not have a well-formed membrane. So in such cases with early PVR, you could use a dye to go ahead and peel these ill-formed membranes. As you can see that it gradually shows you and demarcates that whole area for you very well, and you can remove it under the perfluorocarbon. And at the end, of course, do an air fluid exchange and drain and do an endo laser, the classic techniques at the end, which I used to settle. This is the post-operative picture of this particular case. Now, this is a PVR case where you saw that under PFCL, we've removed the pucker, and now there's a peripheral inferior area which has got membranes which are stuck, and you can see that we've tried to remove them with the forceps as well as shaving that particular area. And there's a buckle also already applied there, and it helps flattening. So if there is a contraction coming up, if PVR changes, a peripheral, if you apply a buckle in these cases, it helps you release some of the contraction. You may otherwise have to do a retinectomy, which you may avoid, or the size of the retinectomy that you undertake can be reduced if you have a buckle. And also it allows you to bring the periphery to the center so that you can see it, the periphery better. So it has multiple advantages in PVR cases. In regular cases, I don't put a buckle, but if there's significant PVR, I prefer a buckle, a belt buckle in these cases. This is again a case of peeling a membrane, which you can see that suddenly it releases the traction and the retina falls back very well. And that's a good sign that the whole tension in that central area is gone. Now, moving to more extensive PVR change, you can see that here it's a much more extensive contraction than what I showed you earlier. And your first step is again to do as much vitrectomy, as much clearing right up to the periphery, because once there's a contraction, you have to make sure that right up to the ora peripheral area, the vitreous or anything in the epiretinal component has to go for you to judge whether the rest of the retina will flatten on its own or you need to make a retinectomy. So here you can see that we are clearing and clearing and clearing, and that's what you spend time on to remove everything that is there, because once that part is totally gone, then only you can take the decision on your next step that you still have residual contraction and you may still have to cut the retina. So you try your level best to achieve as much as possible before deciding on the retinectomy. And then use perfluorocarbon up to the edges of the break. In this case, I'm not sure of the residual traction, so I don't inject PFCL beyond the break edge because it will go into the breaks in case I do. So once again, having put PFCL, it holds the posterior pole, and I'm using the shaft of my light pipe to help me as a second hand to peel off some of these inferior thick membranes which are still stuck up there. And gradually you see that part gets relaxed, and even some other areas, the same situation where there is this adherent equatorial area of a thick attachment. Now here you can see that I'm indenting from the periphery to allow me, after having done all that peripheral peeling, again to shave and remove the last bit of vitreous which is still there. And with every such step, the retina further relaxes. And I stained here also to remove all the residual membranes. And you can see that gradually it keeps on flattening, and we could get away by not doing a classic retinectomy in such a PVR case. So if you do a good cleanup, at times you may be able to get away without doing a retinectomy in these cases. While this is another example of an extensive PVR, anterior PVR that you see here, which is there, and I've started off with trying to remove as much vitreous, the same thing which I discussed in the previous case. Here, the posterior pole is not bad, but all this periphery is contracted. So after having decided that, seeing that it's not relaxing, I decide that I will have to cut some of this area in this region. After having done diathermy, you can see that I've cut off all that stiff edge and I've removed it. And I'm now put perfluorocarbon to the edge, and then I'm trying to remove another membrane, which is to relax some of the retina. And at this stage, you can see that the PFCL just goes behind. So this is something which you need to anticipate, because there's a large retinectomy that you've already created and a huge gap. And now if there is a traction which you're trying to pull at, suddenly the PFCL can go behind. So I remove all that PFCL, come back, first remove that traction without putting the PFCL, and after that put some PFCL. And then I realized that I probably have to do eventually a 360 retinectomy, because even the other areas are contracted. And I started off with partial retinectomy in one region, but I realized that gradually I'll have to increase it to all areas, because otherwise the retina refuses to settle. I always do retinectomy in phases. I will never decide that, okay, I'm doing a 360 retinectomy. I'll keep edges holding on at different areas, because it always helps you do the vitrectomy till you want the retina to be totally free. Otherwise, the retina can get unrolled onto itself or rotates. So it's better to have a few stumps waiting till the end, after which you can go ahead and finish your retinectomy and do a full laser at the end of surgery. So here you can see that we've left a small island of vision in the center in a case like this. This is how it looks like. If you see a post-op view, this is left is the immediate post-op in the week following surgery, and on the right is after oil removal, 3 or 4 months after the primary surgery. The patient still retains a 660 vision with a flat macula, even with all this fibrosis which has taken place because of the retina, which is not healthy, and with the laser marks. But fortunately, the retina holds up well and is seeing 636. A quick step to see how a subretinal band is removed. So subretinal bands at times can be left alone if they're not coming in the way, but at times the retina refuses to settle and you need to relax them, remove them or relax them. So if they come off easily, then you can pull them off. If it's difficult to remove them, then I just cut them and relax them, and they can stay inside under the retina. It doesn't matter as long as the tension created by them is gone. The continued clothesline tension which is coming in is relaxed. So we remove that the subretinal band from there, and the residual edge was on the other extreme end, which also came off with just a suction from the cutter at this end. So at times they will come off easily. At times I will just I cut and leave them, because very often you will burn your fingers by trying to remove them. You may create a larger retinectomy. A bleed may start temporally, which is formed with the macular hole. Now this is a very situation. Posterior and is going to be difficult to manage with solid posterior temporal aspect. So anyways, the first thing is to remove the vitreous as far as possible. Here you can see that there's an adherent hyaloid with blood-stained hyaloid inferiorly. So the blood actually helps you identify the hyaloid well. So make use of it. It's a good thing. Otherwise, sometimes we put triamcinolone on to see the same thing. But here the blood is enhancing your view. So once the retina is the large tear, that of correction. So also take the same ILM and remove it up to the edges of the flap, as you can see here. So it goes up to the flap, so that it helps you relax that particular area, and then of course you iron out those edges, gain as much surface area as possible from the retina, and then do a laser around it and treat it like a giant tear. Now this is a patient with recurrent contractions under oil, and we had posted the patient for oil removal with re-surgery and re-injection of oil, and there's an extensive contraction. So here, a typical way that we make retinectomy is to anticipate the area and then do a good diathermy to the big vessels to anticipate that it should not bleed. And whenever I do a retinectomy, I would make sure that I inject some perfluorocarbon on the posterior pole. Here you can see that there is an oil bubble trapped underlying this area. So sometimes you may not know that, and you have this whole bubble still lying there, which is also creating a problem along with the PVR. This happens if there's residual traction or a contraction which has allowed a globule to go behind. So unless you remove it, the retina will never settle. So here you can see that we remove the bubble. there's still a lot of fibrosis around it, so we gradually are removing that, cutting that area. The bare choroid is seen inferiorly, and then you treat it like a good giant tear, and drain the edges, keep the edges dry, and then do the exchange. Another example of a similar situation, that there was oil, and then patient developed recurrent PVR inferiorly, and so we removed the oil, put in perfluorocarbon up to the edge of this whole traction. After that, did a good diathermy beyond that edge, and then cut that particular retina up to the periphery. So the diathermy always helps you reduce the chances of bleeding, because these eyes can bleed. And also putting the perfluorocarbon up to the edge prevents any bleeder from any blood from trickling to the macular area. So it's got multiple advantages. I always insist that one should put PFCL up to the edge of the planned retinectomy, so that till the time you finish the procedure, it keeps that whole area posteriorly clean, free from blood, and well opposed, and allows you to assess the traction very well. And then, as I showed you, it is treated like a giant tear. We do an air PFCL exchange, gently keeping all the edges of the retina dry from that particular area. Very rarely, I also do retinectomy under oil. If it's not a bad traction, if it's just a mild traction, sometimes I would just make a small retinotomy. And now you see that there's a traction around that hole. So I've decided that I will have to do a retinectomy. So in this case, I keep the oil inside. I've also put some perfluorocarbon under the oil. So it's almost like a sandwich. There's always a space under the oil globule. There's always a bit of an underfill. So compactly, that space you fill up with perfluorocarbon. It allows you a very good opposition of the retina, and you do your retinectomy. Finish your laser, and then take away, gently aspirate this residual PFCL and top it up with more oil. So this is something that is done in cases which don't require too much manipulation. If it's a very thick fibrosis, then I would remove the existing oil and do that. But if I feel that the manipulation required is not much, then I would keep that oil in and proceed like this. This is again a case with a subretinal oil inside with inferior PVR. So you can see that there's a pucker on the posterior pole. What I'm doing is putting a little bit of perfluorocarbon, and you will see how it helps a lot, because as soon as you remove, you put the perfluorocarbon and then remove this pucker, the retina will start to flatten instantly, and allows the PFCL tells you the extent of the traction, and it tells you that, okay, now your posterior pole is clear, I'm keeping it flat. You proceed with your periphery, and now you see that the PFCL has passively pressed out, has egressed out the silicon globule which was trapped inferiorly. So you remove that, and then of course you do your planned retinectomy, because there is a area which still has to be managed beyond that globule. For retinectomies, a good idea is always to remove a few more clock hours than what you think is required, because it's always good to totally relax, then leave that slight bit of tension in that area, because post-operatively that area may come up. Another similar situation with subretinal oil. You can see that this oil-filled eye with subretinal oil which has gone behind. So first of all, we remove the existing oil from the vitreous cavity, and then I put in perfluorocarbon so that on the posterior pole. And as soon as you put in the perfluorocarbon, you can see that you can see that peeping oil globule inferiorly. Now I put perfluorocarbon, and as the perfluorocarbon globule increases in size, it would passively egress out that particular oil globule which is trapped inside, along with the PVR changes, the stiffness which is there. So always you can very passively remove it. All it needs is an opening, and here there's a pre-existing opening. At times, if it's not there, you need to make a retinectomy and create it. Here, of course, the eye would require extensive retinectomies to clear off, to relax the whole area. So you do that and then do a 360 laser in these cases. And I guess one of the last few cases of similar, again, a myopic eye with extensive contraction under oil and would require a very posterior retinectomy along with oil removal under, which is silicone oil globule, which is trapped underlying. Now, these situations arise if a vitrectomy has been done with residual traction or a lot of vitreous left, where you will get this kind of an extensive traction, and the bubble may get trapped behind inferiorly. So always when you do a primary vitrectomy, one has to always ensure a good vitreous removal, which I showed you in the earlier series of cases, and the steps one can take to remove, ensure, use the dyes, use triamcinolone, use indentation, use chandeliers, bimanuality wherever required, so that you can reach the periphery and relax the retina as far as possible without any residual traction, so that these situations don't creep in. So these were a variety of cases that I went through from the basics to complex. I've had a long association with the Philippine retina people. You can see Rory Go, a very close friend. 2009, I had come and he took me to Mindanao to see the Filipino eagle, which I'm very fond of. One of the eagles that I had always wanted to see. We especially went to Davao. We flew down, saw the eagle. I want to come back again. Miguel is going to take me there. He has a small sanctuary there. And you can see familiar faces, Sess and Amy Bottom. They are fellow birders, and we often do some trips together. And Sherman, of course, this is 2009. He has changed since then, but we've been friends for a very long time. And I don't know if he's there on this forum somewhere, but a lot of good friends in Philippines, and I always love to come to your country and enjoy the hospitality and meeting all of you there. Thank you very much for a patient hearing.
Okay, thank you, Dr. Nagpal, for that enlightening talk. I think we missed a few of the poll. Can someone from the technical team show the poll questions from the Slido app to ask you to make a comment? So before we did your lecture, we asked the audience, what part of retinal detachment surgery do you have most difficulty with? Could you quick scan, induction of PVD, post-op care, screening, air fluid exchange? So would you like to comment on those insights of our viewers?
So from this, what has come out is that the induction of PVD is the most difficult. Is that what the poll says?
I don't know. I think that is the last entry. That's why it's really in the middle. Those are most of the.
Okay. So this does not tell you the number of each. It's just that how many different steps are there which somebody could have a problem with.
Yeah.
Yes. So I think it does cover a lot of different areas, and I think during my talk I did touch on almost all those except for certain complications like unexpected hemorrhage or bleeding, and probably those can be dealt with separately. But otherwise, most of the other aspects I did try to. I mean, all the steps did discuss these aspects, right from induction of PVD to each retinectomy making to vitreous space shaving, laser, everything. Yeah.
Okay. Dr. Nagpal, we had a lot of questions in the Slido. We have, I think, 22, 23 questions. Most of the questions here, I think, were answered during your lecture, along with. Okay. So we'll ask Kai to read the first question. Okay, Kai, we'll just go in a quick question. Okay.
Yeah.
Hi.
So the first question is, have you tried using intravitreal methotrexate for proliferative vitreoretinopathy?
No, unfortunately, I don't have any personal experience. I've heard some people having used it and some colleagues, but I don't think I've myself used it. And there's no uniformity on this consensus on its benefit, and so I think it's still a questionable. It's got a questionable role from that end. Yeah.
Okay, so how about the next? What's the incidence of post-op retinal detachment? Sorry, incident of post-retinal detachment surgery, macular hole
Yes,
formation. Yes. Do you see any
yes.
risk factors for that?
So actually, if you would ask me, say from 20 years back, yes, when we started doing macular hole surgery, I did have about a 2 to 3% rate of detachment, and I think that's the time when macular hole surgery had come, and we were learning that it causes inferior detachments at times, because when we peel the hyaloid, we sometimes create area of dehiscence or an iatrogenic break inferiorly. It is predisposed to that area, and if we don't check for them, we don't treat them, then they end up with detachment. So I did have a certain number of cases at that point of time, but somehow I don't think in the last 5 years, if you ask me, I've never had a detachment for a macular hole surgery case. The key factor that I would tell you is that when you do a vitrectomy, you do a PVD, make sure you see the periphery, inferior periphery, because there are many cases when you, as soon as the PVD is,
I think we're having Dr.
Yes,
Manish.
he's frozen.
tear which has come up because of the PVD occurrence. So make sure you see that, and at the end of surgery, you go and do a good barrage laser to that particular area. And I've done that in a lot of cases, and they don't end up with detachment. So I think it's with good macular hole surgery, you don't see detachments anymore. If you ask me.
Okay, great. Okay, Kai, take the next question.
Okay, the next question. Do you perform in ILM peeling in all your retinal detachment surgeries? I would expect.
No, I don't. I
Okay.
only do it for cases which have macular puckers. Like I showed you a couple of examples where there was a pucker I peeled and then did. But if it's just a retinal detachment with nothing on the macula, I don't believe in peeling the ILM for that. No.
Okay. The next one, we'll try to answer. When you depress peripherally with an IOP
Yes.
of 20, is there a problem with valve cannulus?
Well, so yeah, so you reduce it. Well, my normal IOP is between 25 to 30. So I would reduce it to 20 first and then maybe go to 15 and maybe even go to 10 at times. So
Okay.
I would say it's a range, and maybe 20 sometimes is difficult to depress unless it's a very mild depression you are achieving. But if you really want to indent more, then I would say bring it down to 10 or 15 is what I think. Yeah.
Okay, softer IOP, probably. Okay.
Yes.
Good. Okay.
And the next question is, do you routinely do 360 laser retinopexy?
Not for all cases, but wherever I intend to put oil, for whatever reason, my indication for putting oil, those are the cases I do a 360 laser, irrespective of the locations and numbers of breaks, because we found over a period of time that when we do the oil removal, when we have looked at our rates of oil removal redetachments over a period of over long periods, over 5 years data and other things, we found that cases where we had 360 barrage laser, the incidence of redetachments is significantly lower. So if I put oil, I do a 360 because oil is a false sense of security at times, and everything looks good then, and maybe even in the post-op period. But the minute you remove oil, the best of cases sometimes redetach, and I think 360 laser in those cases is good. But if I'm putting gas, I don't do a 360 laser, only to the brakes, intended brakes. Yeah.
Okay. How about using dexamethasone, heparin mixed with the
No,
BSS? Okay.
no, I don't mix anything on that. No.
Okay.
Okay.
Right.
And the next question is, can you comment on the findings of the pivot study that uses perfluorocarbon on routine RD surgery associated with more vertical and horizontal distortion?
Uh, I don't think I use it from that context. I use it not to totally fill up and then just do the laser, except for GRT, giant retinal tear cases. I prefer doing an air fluid exchange. PFCL is only for the posterior pole. I think this happens more if you fill it up and laser and never go to air at all, actually, and you only do the tamponade at the end. So I don't think I've seen that problem of distortion in that situation. But I use PFCL very routinely for most cases. Yeah.
Okay. So the next question. Have you had a chandelier hit the lens after drainage in the buccal in the soft eye? Any
Chandelier
experience?
hit the lens? No, not myself, but I know of that eventuality. In some of the meetings, a couple of people have showed me that can happen if suddenly. So one, I think, has to be careful if you drain. I'm always ready with a 30 gauge needle and a 2 cc to inject air. As soon as I feel that the tone of the eye has gone a bit lower than I would like it to, I would instantly inject air and then carry on with the rest of the procedure. But if it's extremely short, extremely soft eye, this can happen. Yes.
So you leave the chandelier while you drain, doctor? Do you still leave it,
Yes,
or
of course.
the okay?
I leave it because of the one simple reason that as soon as I finish drainage, I do want to check inside quickly for any sign of a bleed.
Okay.
Because if you remove the chandelier, then do the drainage, and then when you check and you have to re-put the cannula, it takes away some time, and I would rather not have that much time wasted. I keep the chandelier on and drain, and have a quick look
Okay.
inside. If there's no bleed, everything, then actually I will take off the chandelier and do the suturing outside. But if I
All
see
right.
something that needs to be managed, I would rather do it then. And so the chandelier helps at that stage. Yeah. But
Okay.
So
during the process of
usually,
suturing, I remove the chandelier because otherwise
oh,
that comes in the way. Yeah, yeah.
Okay. Okay.
okay.
Okay.
So next question would be, how do you usually manage RD without PVR with inferior breaks? Do you use the encircling band or just
No,
PVR?
most of if there's no PVR, I'm not putting bands anymore. I used to in the past, but today I feel that with no PVR, if you are able to flatten it well without having any membranes, no other things are there except the vitreous. I just do a normal vitrectomy. But if I see PVR, yeah, it's probably a good idea to put a band.
How do you prevent post-op visual distortion with no macular fold and OCT?
Again, I think the key is to use PFCL on the posterior pole while you're doing the rest of the lasering, everything, because that keeps that shallow fluid pocket which keeps coming otherwise and trickling onto the macular area and creating different planes. So I think if you keep that PFCL on till the end of your surgery, till you finally require to drain it during the exchange, I feel that probably is a good factor to prevent a fold there.
Okay.
Okay, so do you prefer using a sutured lens ring to hold your mini quad versus that of an SSV?
No, I use an SSV and I don't suture any ring. SSV is great for stability. It just sits very well without doing anything. All I do is sometimes nudge my finger to kind of in case I feel there's a slight tilt in certain situation, I would just use my finger which is holding the fiber optic to nudge it. That's all, but it sits quite well without any support.
Yes.
Okay. For retinectomies, what is your most posterior extent to determine whether the retinectomy will result in flattening of the posterior pole? Up to where?
I think up to equator, and sometimes I do in the situation that you are trying to question. Maybe a few radials is what I might use because I will not come below the equator to do a circumferential retinectomy typically. But if I feel that there's still a lot of stress, I may do a few radials which could come closer to the arcades, which just allow that relaxation
Okay.
along with the peripheral the circular retinectomy that we do.
Okay. Next question would be, what buccal type do you use for PVR?
or just a belt buckle, the band, the 256 band. That I just for the PVR, it's just a band, that belt buckle that I put in. But for my buckling surgery, I prefer a 5 millimeter sponge. I prefer a sponge over a hard silicone. I've trained with that, and I'm more comfortable with that. So for that, I use a sponge. But for just a support for a PVR, in where I'm going to do a vitrectomy along, I just put a belt buckle.
Okay. So the next question, for closed funnel retinal detachments, do you do PPV sterile buckling or PPV retinectomy?
Well, actually, both. There are times I feel that this requires a 360 retinectomy, and so the buckling has really no role. I already know it, so I go in with the idea of that I don't want to put buckle, and then because there have been cases where you put a buckle, you go in, then you do a 360, and then I remove the buckle. So sometimes you have a very clear insight looking at the retina, but there are times when you're not sure, and you feel that you may get away with less retinectomy. I would put them for a combined procedure and take it from there.
Yeah. Okay, next question is a technical question. For simultaneous perfluorocarbon and oil exchange, do you prefer to do active extrusion versus passive? And if you do choose the active one, what are your settings for this one?
Well, I personally don't do a simultaneous one because, again, I've been trained with the I've been trained with the graded exchange from air to PFCL and then PFCL to oil. So I'm very happy using it. I just make sure that I keep the edges dry so that slippage doesn't occur, and I don't get slippage. But I think the most of the machines now, vitrectomy machines, allow you to do a combined extrusion by a setting where you could just directly with the foot control do both together, is my understanding. But I don't use it, so maybe the technical part I may not be able to tell you that much.
Okay, thank you. Carlo, next question.
Yeah. How do you judge how much retinectomy is adequate for a case?
Again, so as I showed you through my cases also, that as soon as I remove vitreous and I'm seeing some contraction or some need for retinectomy, I start putting perfluorocarbon up to the edge of where I feel the retina is flattening well. And from the area that the retina starts tenting, you get a fair idea that after having removed membranes, vitreous, if that tenting is there, in that whole region, you do require a retinectomy. So you plan it for that area. Also go a few clock hours on both sides where you feel it's already relaxed, because that's the only way you can get a full relaxation. And so diathermize all that area of the large vessels which are passing through that area, and then do the retinectomy. Yeah.
Okay. What is your opinion on retinectomies on pediatric RD with PVR?
Well, again, you don't want to do a retinectomy in any case wherever it's possible, but pediatric RD also, wherever there is a stiffening or a PVR which is caused a contraction which you cannot relieve by just removing the vitreous, you do have to resort to retinectomy. So I treat it pretty much the same as an adult one if it's required. In fact, there you want to be much more sure of the relaxation, because these eyes, the peripheral vitreous, you can never really totally remove. There's always some, no matter how much you shave, you still have some attached, and that creates a problem in the post-operative phase. So they don't do very well at times. The pediatric ones, they may be more aggressive in redetachments, but if it's required, you have to treat it the same way.
Okay. Here's one question from YouTube. Okay. What specific type of contact wide field viewing lens do you use? And is it a handheld lens?
Yeah, so I use the Vogue contact lens. It's a contact lens with the SSV, which they describe self-stabilizing. It's got these flanges, so it just sits there. You can put some viscoelastic and put it on top of that, and pretty much stays there except for a mild tilting that you may nudge it around. Also, it has a handle. You could have an assistant also just hold it with a handle for you there. Some people do that also. I prefer it to just keep it independently on that. So these are the Vogue, the Mini Quad XL is one variety. The HRX Wit is another variety. These two lenses are pretty much, they almost show you up to 180 or 190 degrees wide field viewing, which are excellent for seeing the retina as a whole right up to the periphery. And if I want to do a very fine peel on the macula, like an ILM or a membrane, I switch to a flat lens. Again, a Vogue flat lens. It's got flanges. Vogue Chalum lens, it's called. It's got 2-3 flanges. You just put it on top, and it's a regular flat lens which gives you very good magnification and stereopsis to do a fine peel. So for those procedures, I switch to that. For that much part of the procedure, I switch to that lens. But most of the rest of vitrectomy is with the wide field viewing contact lens. Yeah.
Great. Yeah, you have very nice videos and very clear. So
thank you. I think the contact wide field tends to give, I feel, the non-contact.
Okay. Yeah. Even your viewing system, even your videos. So it's based on your whole system. That's really nice. Okay.
Yeah.
Okay. Kai, okay. We have, I think, last 3 questions. Kai, would you like to read the last?
Okay. So
a few more.
Yeah. How do you manage submacular or subfoveal subretinal bands?
Right. So that's a tough question because, again, if, as I said, if there's a subretinal band, whether it's passing through the central part or peripheral, as long as it's causing a tenting, something has to be done about it. But there are times when it does not lead to tenting. It's just passing through that inferior long-standing detachments. You might see these bands. And we know that even with buckling surgery, you drain and the retina goes flat. The band is still there, but is not causing any problem. So if the retina is flattening, even with a submacular subfoveal band, I may not go to remove it because I feel that by disturbing it, you may cause more harm. But if it's leading to a tenting, then I would try to find the ends of, it usually will not be limited to macula. It would be going from one end to the other. I would go as far away from macula where I can get a good hold over it, and then try to explore it from there. If it comes out easily, I will pull it off. If it not, I will relax it at 1 or 2 places and then leave it there, because otherwise, if you aggressively try to remove this, you may end up with a problem right at the fovea.
Okay. So I think the next question, I think you've answered this during your lecture. How do you manage submacular or subfoveal or subretinal bands? I think you answered it.
Yes.
Already. So for the last question, preferred density of silicone oil. Do you have any special oil that you want?
Yeah, so I typically use the 1300 centistoke oil, 1000 to 1300. 1300 is what I use presently. It works reasonably well. I'm not very fond of 5000 centistokes because it tends to be very difficult, more difficult to remove and inject everything. It takes more time. But I think only that for various reasons. But typically, I prefer a 1300, which works well. It's easy to remove, easy to put, and yeah.
All right. Yeah. So thank you very much. That's great. Okay, Kai.
Okay,
thank you, Doctor.
Thank you very much, Dr. Nagpal. We enjoyed talking to you, and unfortunately, that is all the time that we have for now. Thank you again in your comments and your questions. For those questions that we weren't able to entertain anymore, don't you fret. We will try our best to address them and send you the answers.
All right.
So thank you again, Dr. Nagpal.
Thank you very much. It's been a pleasure being with all of you.
Yeah,
thank you so much. Be well and stay safe. Thank you.
Thank you.
Same with you, the medical advisor for ophthalmology and established products of Bayer. She would like to talk to us about Bayer's commitment to ophthalmology.
In terms of ophthalmology, there is a focus on innovation, education, and collaboration. So, in terms of innovation, it's optimized, and I'm sure. So, you'll see here wet AMD, DME, RVO, and myopic CNV. And here we also have incoming indications like neovascular glaucoma and ROP. So, we are looking at various indications coming in as well, which I will discuss also later. But aflibercept has been available for 9 years worldwide and approved for 5 indications in 3 years. So in terms of wet AMD, I'm sure you all have heard and also know that there is excellent durability wherein we can extend patients up to 60%. 60% of them are able to reach the interval of Q12 and about 46% are able to reach 16 weeks. And this is based on the as a drug of choice. For those with a visual acuity worse than 69 ETDRS letters or those with baseline worse vision. And this is based also on the Protocol T study. For RVO, in the LEVO study, we see here that there are numerically greater BCVA gains versus ranibizumab and bevacizumab with significantly fewer injections or not inferior based on statistical analysis. So speaking of TNE, which is something Bayer is investing in, especially because it has become there are ongoing TNE studies, and actually most of them have been completed and are waiting either presentation or publication and Azure. And also a growing base of RWE in 20 countries worldwide, which will help us provide valuable insights on how we can better use aflibercept in clinical practice. So that's for the first pillar. The second pillar really is enhancing clinical knowledge and education. And one of the initiatives is the Vision Academy, which is actually a congress or a congregation of 100 experts worldwide who address clinical challenges in ophthalmology. So it's a platform where experts can give guidance or provide guidance for best clinical practices in the management of various retinal diseases. So you'll see here that there have been a wealth of public hemodepside, which is being studied for river blindness. So when we have more data on these upcoming indications and molecules, we will be more than happy to update you guys with what's going on as well. So particularly for ROP, so there are ongoing studies. We see here that ROP is one of the phase 3 comparison between aflibercept and laser photocoagulation, and they decide to observe absence of active ROP and unfavorable structural outcomes at week 24. But there also is another phase 3 study, which is the butterfly. So this one is at week 52. So it's the same study design, but this time at week 52. So estimated completion of butterfly is April of next year. So really, in summary, Bayer is committed to optimizing therapy for individual patients through achieving the best possible vision gains and really reducing treatment burden with aflibercept. And through innovative products and research, they help reduce the number of people affected globally by visual impairment. So Bayer is continuously collaborating with stakeholders and new research and developing innovative products, but also really preventing vision loss and preserving healthy vision for our patients. So that's all. Thank you again for this opportunity and hope you have a good night and a happy weekend.
Okay, thank you again, Bayer, for supporting this episode. So, bawal pa ata ako mag-video. Nakalak. Well, anyway,
Yeah.
Kai, to sum up our evening for tonight. No, tonight, Dr. Nagpal beautifully demonstrated several useful techniques for retinal detachment repair. He advocates the use of a chandelier and illumination that will allow him to perform bimanual techniques, including sterile indentation. He also uses chandelier combined with a wide angle viewing system for pure star buckling purposes, which provides excellent visualization. And the importance of PFCL in very complex cases. No? So he uses a lot of that. And lastly, he showed us several techniques in addressing PVRs in order to improve surgical success rates and outcomes. That was a very long Q&A, guy. I know. And
Yeah.
that was another action-packed episode. Thank you again, Dr. Nagpal, for engaging this evening with us. I think is he still online? But thank
I
you
think
again.
this,
I think you can watch it. We can watch it in YouTube, I guess.
yeah,
All
we
right.
can. Okay, so thank you again for attending the 17th episode of the VR channel. Before we go, let me make a shameless plug for the PAO Connect app. Don't forget to download and register. You can check your email for the verification code. For any inquiries or problems, email at paomdconnect@gmail.com. So, just for a few reminders before we close this session, please scan the QR code to send us feedback and receive your certificate of attendance. You can also click on the link posted on the chat box on YouTube. The form will be accepting responses for up to an hour. Thank you again. It was a very, very fun night.
For those who missed the previous episodes of the VR channel, they're already available for viewing at the VRSP website. So check vrsp.org.ph. But before we end this, we'd like to thank the VRSP tech team. Jubes,
Yes.
Camille, Nori, Joanne, Rob, Kuni, Nika, Paul, Tim, and the birthday boy, Dr. Nico Agustin. Happy birthday
Happy
again.
birthday.
Sayang wala yung picture. Hindi ko dala. It's in my wallet.
Oh, God, we were supposed to put up the picture in the wallet. Wait,
All
just
right.
kidding. So happy birthday.
Happy birthday. Okay, you'd like end it, Kai. So we have Saturday.
Yes. Okay, so thank you everyone for participating. Join us again on our 18th episode of the VR channel with Dr. Tomas Castro Feju in 2 weeks' time. See you, same time, same channel.
Bye.
Yep. Bye.